could also introduce yourself since it's been a little bit. That'd be great.
Yep. And I guess we should make sure. Goody, we are recording. Good. So, hi everyone. Welcome to Unremarkable Labs. I'm Drew Srinivasachar. I am a fourth-year medical student currently in the throes of interviews for MedPeds. Back again to discuss, and I'll turn it over to Mario.
Hi everyone. First of all, can you hear me? I'm not sure if my audio is working. Okay,
Perfect.
Cool. Hi, my name is Mario. I'm a fifth-year med student from Lima, Peru, from Cayetano Heredia University. And yes, I've been listening for a while to this podcast and also the CP solvers. And it's really an honor to be here and discussing.
Awesome, that's exciting. Some of you may have met me before. I'm Meagan Gray. I'm one of the transplant hepatologists at UAB. So we did the first episode of Elevated Liver Test a couple of months ago, and so we're back for more.
So this is round 2. So round 2, we have a 24-year-old female presenting with fatigue and nausea for the past month, and she has these LFTs. So she has a total protein of 7.5, albumin of 4.2, total bili of 0.5, D-bili of 0.2, ALT 202, AST 134, ALK phos at 205. So Mario, you get these labs. What are you starting to think about?
So when I think about liver chemistry tests, I like to organize them into, especially when I'm addressing elevated bilirubin, I like to address it as an isolated elevation, meaning if there is a elevation if there's none, and if the transaminases are normal and the ALK phos and GET and so forth are normal, or if it's bilirubin, an elevated bilirubin associated with altered transaminases or ALK phos. And in this case, it's pretty remarkable that the transaminases and ALK phos are really elevated. So I think the first thing I would like to do right now is try to determine which predominates, if it's the transaminases that are more elevated than the ALK phos, or vice versa, because that would gives us a hepatocellular pattern or a cholestatic pattern. And in this case, I think that ALT and SAT, especially the ALT, that's more specific for the liver. It's way above the upper limit of normal. And that doesn't mean that the ALK phos isn't elevated, but I think that the transaminases are way more elevated in proportion than the ALK phos. So I think I would categorize this like as a primarily hepatocellular pattern.
Great. So Drew, you have anything to add?
Everything that Mario said, and I guess in terms of questions that I would want to ask further, especially since this is a 24-year-old, I'd want to know a couple of things. One, given that she's had fatigue and nausea for about a month, I don't know if she's had any exposures within that month that might cause those transaminases to go up, for instance, alcohol. But the other thing that I want to ask is about her immunization history and her immigration status, because the one thing that we do want to not forget in our differential are the viral hepatidities like Hep B and Hep C. Hep C would probably be far more common, but given that this patient is so young, we probably would want to ask about vaccination status. She probably would have gotten her Hep B vaccinations if she was born in this country, but who knows?
Okay, so it kind of sounds like you're thinking along the same lines as Mario, that this looks more hepatocellular, and you're concerned about like a hepatitis from a virus. Dr. Gray, what do you have to add when you see these labs?
Yeah, I think there are so many different things that can cause this type of liver injury. So I think you guys are definitely on the right track. So certainly chronic viral hepatitis could do this for sure. Autoimmune hepatitis could also do that. She is in this young female range, which would definitely be one of the peaks for when we see the first presentation for autoimmune hepatitis. So that's definitely on the list. I would also want to know if she's pregnant. Certainly we can see these types of liver enzyme elevations in pregnant patients, or if she is potentially pregnant, I guess. And then, some of the autoimmune, or besides autoimmune, some of the genetic disorders, right? So alpha-1 antitrypsin could do this potentially. I have seen NAFLD do this, non-alcoholic fatty liver. It would be, these level of enzyme elevations are somewhat high for NAFLD, but we have seen this. Not quite the pattern that you expect with alcohol, but certainly alcohol would be on the list. So there's really an extremely broad differential for this pattern. So getting some more history should be helpful.
Okay. Yep. So, Drew, I'll let you go first. What's the first two questions you want to ask this patient? And I'll give you that information.
So, one, is she pregnant?
So
And
she doesn't know. I'll tell you that her last period was 2 months ago.
Interesting. Because usually when you think of HELLP syndrome or any of those other ones, you would think that those would occur closer to the end, so like closer to like the third trimester of pregnancy, and those are indications where you would deliver the pregnancy. And then I'd ask about her alcohol use.
Okay. So for her alcohol use, she said that she drank 2 Coronas on her 21st birthday, but otherwise says she doesn't drink at all.
Odd.
Mario, what would you like to know?
Well, besides questions that are already written, right? Like, I would like to know also the immigration status and vaccinations, but maybe if she's noticed any change in her skin color, like does she notice any jaundice or pallor, or has she noticed some changes in stool color or urine color?
Okay. So she hasn't noticed any jaundice at all, hasn't had change in skin, urine, stool. Yeah, you have one more question, Mario, before I turn it over to Dr. Gray.
Maybe like more background information, like does she have any the type of pets, or does she eat, does she here in Peru it's a really important question to ask if they have good hygiene while eating their foods because of different infectious diseases. So maybe something like that, or also if she traveled. I'm not sure if that's inside immigration, but maybe has she traveled anywhere, maybe some tropical countries recently?
Okay, so she's from the US and hasn't had any recent travel. And so Dr. Gray, what are kind of like the questions when you get a set of LFTs that are the first questions that come to your mind?
Yeah, I think you have to just think about your differential first. So if we think she might be pregnant, which you haven't told us she's not, so I still think she may be, then certainly, is she able to keep down food? Has she just been having, severe nausea, vomiting? Is she itchy? Thinking about intrahepatic cholestasis of pregnancy. So that kind of goes with your pregnancy differential. And then for viral infections, has she had fever, diarrhea, either any other type of viral syndrome, achy, that kind of stuff. And those would kind of be the big things. Certainly, is there a history of liver disease in the family? Has she ever had elevated liver tests in the past? Those things are all really helpful.
Okay. So she hasn't had any fevers. She hasn't had any achiness. No real family history of liver dysfunction. The only reason these LFTs were checked is because of this fatigue and nausea that she had presented with. And so her PCP had checked like a CBC, a thyroid, and a BMP plus LFTs and had this.
And then I guess if she had any weight loss, I always pretty much find a reason to ask that to everyone.
Okay, what are you thinking about when you ask about that?
I just lost my train of thought, but I did have, I guess just like nutritional deficiencies, thinking about her being tired, celiac disease can cause abnormal liver test. So if she's been losing weight.
Mm-hmm. Okay, yeah, she hasn't had any weight loss. And I remember earlier you asked if she had had any diarrhea. She hasn't had any diarrhea either. She hasn't had any like IV drug use. You guys had also mentioned like vaccinations earlier. She's not sure if she's ever been vaccinated for hepatitis A and B, but she's like, the flu I get every year, Tdap, I'm up to date with, but she's not sure about Hep A and Hep B.
And then I guess any abdominal pain, thinking about gallstones or choledocholithiasis.
Okay. Yeah, so she hasn't had any abdominal pain with this. So this was kind of a surprise to everybody at this point.
And I guess the other thing that I'd want to ask is any other history of any other autoimmune conditions, and in particular with her fatigue and nausea, I'd want to ask, or like, sort of, there's nothing to suggest it, but I'd want to ask about things like Crohn's disease or ulcerative colitis, which have liver sequelae along with it. I'm trying to remember which one goes with which. I think Crohn's is associated with PBC, if I remember correct.
Usually PSC is associated with ulcerative colitis, but you can sometimes see autoimmune hepatitis as well.
So I'll tell you that her past medical history is just GERD, and she takes like a PRN Zantac. But that's about it. Like when she changed her diet, like away from spicy foods, GERD went away.
And then I think we always have to throw in like toxins or supplements. People are increasingly taking these. So any new supplement she started taking, or it sounds like not any new prescription medications, but supplements are also really common.
Okay, yeah. So she takes a daily multivitamin, but that's it. Doesn't take any like pre-workout. Doesn't take like any herbal supplements for mood, like St. John's wort or anything like that.
I see somebody in the comments asking about sexual history, which is also a really good question.
Yeah.
So we can see syphilis, hepatitis. So those are good thoughts.
So she's monogamous with her boyfriend, and they've been together for, I can't spell boyfriend, but they've been together for about the past year. She has no other sexual partners.
Your happiest moment, family spending time together.
And the chat asks if the boyfriend is monogamous.
He's not there, so he can't defend himself, but she swears that they're serious. Any other questions that you would like to know as part of like your history before you start digging into these LFTs a little bit more? It looks like Dr. Centaur is asking about a sore throat. Could you tell me why? I'm actually kind of struggling to put that one together.
Could this be a monosyndrome, either EBV or CMV? And
Okay.
that might start with the sore throat and then fatigue.
Yeah, great point. So no sore throat.
Did you tell me if she was itchy or not? I'm looking back, but I don't see it.
I don't think I ever told you. She's like, not that I really think, but now since you said it, now I'm itching. Kind of a thing is what she said.
Okay.
Oh no.
And I haven't given you the BMI yet, but her BMI was like 24. And it's been like that as far back as you can see in the computer system.
Okay.
So Drew, what are you thinking about right now? Like what's your most likely thing, and are you starting to think about labs, or is there some extra questions that you want to ask?
Right now, it looks like a whole lot of nothing. And so the fact that she's not sure with her Hep A and Hep B is
Not enough. Jin Young's Johnson help from the sourness too.
concerning, but since she's from the US, I'd probably take stock in the fact that she probably got at least one dose. There doesn't seem to be much of anything that would suggest that she has anything like AFlip or HELP syndrome or interhepatic cholestasis of pregnancy or anything like that, because although I would want to get a pregnancy test regardless, even if we're especially considering if we're going to CT for imaging, we're going to get a pregnancy test anyway. I guess the other thing, they said no changes in the skin or anything like that. I would want to ask about things like hematuria or anything that would is essentially any symptoms that would indicate hemolysis. Although, actually, come to think of it, scratch that. Her billy is fine. It's the transaminases that are screwed up. At this point, I'm getting a little bit lost. I'm trying to figure out what can cause isolated elevation of transaminases and alk phos without elevation of billy.
Mm-hmm. So Dr. Gray, what do you think when you see that, like a normal billy but elevated everything else?
Yeah, I mean, that's extremely common. Any sort of diffuse hepatocellular disease is very likely to raise the alkaline phosphatase. Upper limit of normal for alk phos is around 120. So I'd consider an alk phos of 200 to be kind of mildly elevated, which is very common in any diffuse hepatocellular disease. I think the differential is still extremely broad. I think she could have a viral infection. She could have autoimmune hepatitis. She could be pregnant. Without blood work, I think we're stuck.
Well, it sounds like you guys kind of want to move on to blood work. And so Mario, I'll let you kind of get the first couple says in what we check. So what would you like in terms of blood work?
Good. Has always been mankind's process.
I think first, CBC, I would like to see the hemoglobin. I also would like to maybe also order viral hepatitis panel, including Hep A, Hep B, Hep C. I'm not sure if it's too early to order like autoimmune markers like ANA, AMA, or not total IgG. But I think those will be my first thoughts.
Okay. So Dr. Gray, when do you think about like ordering that autoimmune panel?
So when patients come to our clinic, this is a very common clinic patient presentation. They get about 15 vials of blood drawn. So they get all of the things that you mentioned, autoimmune testing, iron studies to look for hemochromatosis, alpha-1 antitrypsin level and phenotype. So they get the whole gamut. So I think none of that is unreasonable. And then, of course, I think we also want a pregnancy test, right?
And I think in the chat they also wanted an HIV status as well.
Absolutely.
See if there's anything that can broaden the differential.
Okay, very good.
So and a TSH apparently.
And the TSH.
Because I think in the chat there was discussion about how hypothyroid can lead to liver issues.
So I'll give you her TSH right off the bat because they got that with the normal tests and it was 3,000. Just kidding. It was only 4. So it was normal. Her CBC, she had a white blood cell count of 5.9, hemoglobin of 12, and her platelets were 243. For her hepatitis panel, Her Hep A IgM and IgG was negative. Hep B surface antigen envelope was negative. HCV was negative. So all of those were negative. For her iron studies, her iron SAT was normal, but her ferritin was like 100. Like iron SAT was like 30%.
Okay.
Pregnancy was negative, and I'll tell you that she has a history of irregular periods, so it was a little bit of a red herring. HIV status was negative. And then in terms of the autoimmune panel, what all do you order when you have that? Because unfortunately, I don't think it's not a panel that is easily orderable at UAB.
Yeah, so we checked that there's 3 kind of key things you need to check. So 1 is the anti-nuclear antibody. 2 is the anti-smooth muscle antibody, or F-actin at some centers. And then the 3rd is a total IgG. Those are the 3 kind of most high yield antibody panel. You know, thinking about, there are other autoimmune tests, and thinking about things like PBC, you know, she's really not the right demographic. It's typically older women. So although you could order an anti-mitochondrial antibody, I think it's low yield.
Okay. So her ANA and her ASMA were both negative. Her IgG was 2,900. And the upper limit of normal is, I think, like 1,600 or something like that.
Yeah, that's actually very high.
So we have all these, and I'm kind of curious if you guys want any imaging, and if you want imaging, what are you thinking you might see?
I don't know if a liver ultrasound would actually show much. Even though the transaminases and alk phos are high, a lot of the things, a lot of the more classic imaging findings of things like cirrhosis, you wouldn't necessarily see those the high AST, ALT, and alk phos, because the hepatocytes are essentially trashed. I would probably also get a CT, considering that IgG is quite a bit higher than the upper limit of normal. IgG4 disease is on the differential, and I'd want to see if there's any lymphadenopathy in the abdomen and retroperitoneally.
Okay. So actually I didn't get a CT abdomen, but I did get an ultrasound. And it was completely normal, with normal homogeneous echo texture of the liver and of the spleen. So Mario, what are you thinking about, and has anything helped you out so far, or?
Yes, I think that this last finding is reassuring in terms that a lot of the liver inflammation, different diseases that cause liver disease can progress to cirrhosis, and I think the normal findings in this ultrasound, and also that we don't have an INR, but the albumin is normal, so the synthetic function of the liver seems to be preserved. I think that's important. But in terms of finding the diagnosis, I think that the elevated IgG, but accompanied by this negative ANA and ASMA, I think I'm not sure what the sensitivity of this ANA and SMA for albumin hepatitis are, but I'm really not sure how to. I'm really not sure if this helps me to find a diagnosis. I know that if we were thinking about alpha-1 antitrypsin deficiency or hemochromatosis or Wilson's disease, I believe that we would the presentation would be accompanied by extra hepatic symptoms. In alpha-1 antitrypsin deficiency, maybe some bibasilar fibrosis or something like that. So I think that I think what I would think it's still on the table are the autoimmune diseases. Maybe I know there are some seronegative hepatitis viruses. I think those are more associated with in medullary suppression more than hepatitis, like hepatic inflammation, but maybe some atypical infection could still be in play.
Okay, so I'm kind of hearing that you feel like we still haven't ruled out autoimmune, that it could be maybe a little bit weirder of an infection than we normally test for. And so, Drew or Dr. Gray, are there extra tests that you would want to order? And I'll give you an INR, since Mario, you had mentioned that it was 1.18. So you're exactly right with her albumin and that INR being normal. It seems like her synthetic function is doing pretty good. So Drew or Dr. Gray, what thoughts do you have at this point?
I'm happy to talk, but if you have any thoughts, go for it.
The floor is yours, Dr. Gray.
Okay. So you can see autoimmune hepatitis with negative serologies sometimes. And so the fact that the ANA and anti-smooth muscle are negative does not completely rule out autoimmune hepatitis as a cause. So somebody in the chat wrote about some of the other liver enzymes, or I'm sorry, liver antibodies that we check for autoimmune hepatitis. So they mentioned the anti-liver kidney, soluble liver antigen. These are other antibodies. I would say for the most part, we don't routinely check them. They do take a while to come back, but they are definitely things you can check, especially in a younger patient. It's possible that they may be more likely to have one of the less common antibodies. We still haven't checked like EBV or CMV PCRs. So I think that those tests can be helpful. It is reassuring to see that her spleen size is normal. And then in terms of IgG4 disease, I guess in the liver, we most often see that present as a sclerosing cholangitis. So it would be something that would more be picked up on an MRCP. I would say that with an alk phos of only 200, that's not really very high on my differential. You can order IgG subclasses, which will give you IgG 1, 2, 3, and 4, and that would be the best way to look for an elevated IgG4. But certainly other things can cause the IgG to be elevated. I do notice she doesn't have a protein gap, so that's reassuring. I'll have to have my internal medicine colleagues help me out with all the different things that can make your IgG elevated, because in my world, it's usually autoimmune hepatitis or lupus or rheumatoid arthritis. They usually have some autoimmune process.
Mm-hmm. If she did have a protein gap, what kind of things would you be thinking about more so in her?
Yeah, you can see liver involvement with myeloma. And so I would think about that.
Okay.
I actually have a patient just a couple of weeks ago that has plasma cell dyscrasia, and we actually found it on their liver biopsy. So not common, but we do see it every once in a while.
Okay, cool. I did not know that. So I can give you the EBV and the CMV serologies, since you had mentioned those, both negative. They were both PCRs, excuse me. So she didn't have any of those circulating around. What would you like to do next, Dr. Gray?
I would like to biopsy her liver.
So she did get a biopsy performed after like a month. So what had happened was they wanted to repeat them in about 4 weeks just to see if it was some weird lab thing, but they all remained about the same. ALT was maybe a little bit more elevated. But she ultimately did get a liver biopsy performed, which had an inflammatory lymphocytic infiltrate in the portal areas and severe interface hepatitis. Her bile ducts were normal. And so I guess the pathologist took the day off at that point And so when you get the liver biopsy, what do you think about?
Yeah, so we typically expect like a mixed inflammatory infiltrate. So often they'll have lymphocytes as well as plasma cells in the portal tracts. But the interface hepatitis is very classic for autoimmune hepatitis. So on your step exams and board exams, that's your keyword. So basically, the interface hepatitis means that the inflammatory cells are sort of spilling out of the portal tract into the lobule of the liver, and that's very classic for autoimmune hepatitis. We do like to see plasma cells, so I would like to see the pathologist say something about plasma cells. But so far, that is very consistent with an autoimmune picture.
Hmm. And so she actually did get some more antibodies sent off later, and she had positive anti-liver cytosol type 1. So
Nice.
ultimately was diagnosed with autoimmune hepatitis. She was started on prednisone and had normalization of her LFTs in about 4 weeks after starting on her prednisone. And then she stopped taking it and relapsed.
Oh no.
And then started taking prednisone again, plus azathioprine, and went back into remission. So, Dr. Gray, what kind of thoughts do you have when you have autoimmune hepatitis? Like, what are your pearls? Like,
Yeah, so I mean, definitely a young patient. So the sort of two peaks for autoimmune hepatitis would be sort of this age range, so sort of teenage to 20s, and then the second peak is really sort of in the 60s, that older age range. And so she definitely fits in that picture. It's extremely, the presentation of just kind of being tired and just not feeling well is very common. I would say that's probably what most of our patients complain about. So like, I think this is a perfect example of the fact that you can't rely just on the ANA anti-smooth mocell IgG, especially if your concern is high. So really, if any one of those three things is abnormal and everything else is coming back negative, that is a patient I would go ahead and biopsy, so they don't have to have all three of those things. And then, sometimes, like I mentioned, we don't always send off those less common antibodies. So one of the other diagnostic criteria that you can use is their response to steroids. So that's actually part of the diagnostic criteria. So if they do respond to steroids, that helps you clinch that diagnosis. So the fact that her liver test normalized with steroid treatment really helps you. And then in terms of treatment, I mean, people do things a little bit differently. So certainly if you're not 100% sure that you have the right diagnosis, then I think a course of steroids is very reasonable. With liver tests I mean, they're elevated for sure, but sometimes we see patients with autoimmune hepatitis that have a bilirubin of 20 and, these really intense, severe cases with ALTs over 1,000. So that patient for sure needs steroids. This patient, I think you could argue that the liver tests aren't super high and you could probably just start her on treatment. So treatment, first line therapy is azathioprine. So generally we use anywhere from 1 to 2 milligrams per kilogram per day of azathioprine. The one thing to know about azathioprine is that it can cause a cholestatic liver injury. So in someone who does present with jaundice, an elevated liver test as their initial presentation of autoimmune hepatitis, I don't use azathioprine until the steroids have calmed down that inflammation, because if the jaundice isn't getting better, then you don't know if they're just not responding to steroids or if you have a drug injury. So I think it's always better to wait till the liver tests have got, or at least the jaundice has gotten better, but her bilirubin's normal, so she would be fine to go ahead and start azathioprine. Of course, pancreatitis is a risk of azathioprine. And for patients who don't tolerate it for whatever reason, Cellcept is a really great, or mycophenolate is a great second line option. It works really well too.
Yeah, that's great. That's definitely more than I had known, even about like the diagnostic criteria. I didn't realize that the response to steroids is part of it. But I thought the main thing that I had learned from this was you can't just rely on a negative ANA, all your antibodies, that it can be fairly common for them to be negative and they just deserve a biopsy anyways.
Absolutely. Yeah, especially if they have a really severe flare, that's when it's more typical that you may see negative antibodies, but clearly this case shows that it can be more than just those cases.
John, I have a couple of questions if that's okay. Of course, because I'm going to ask them. So the first question is, I once heard a case presented where the patient did have arthritic complaints in addition to the autoimmune hepatitis. How often do you see those kinds of complaints?
I would say we very commonly see autoimmune hepatitis overlap with other autoimmune diseases, whether that's hypothyroidism, which would probably be the most common, but also rheumatoid arthritis. So I guess for a patient who has autoimmune hepatitis alone, I would say I don't see a lot of arthritis complaints, but certainly I would refer them to rheum to see if they had rheumatoid arthritis, if that was a complaint that they had.
Another question is, what is the prognosis of autoimmune hepatitis in 2020?
Yeah, I mean, these patients, if you get them on the right regimen and you normalize their liver test, they can have a completely normal life. So that assumes that they respond to treatment and that they actually take their medication, which in a 24-year-old is not guaranteed. But yeah, the prognosis is just completely related to whether or not, well, one, I guess how much fibrosis they have at the time of their biopsy since she's young. I don't know if you mentioned how much fibrosis she had, but fibrosis can regress with treatment. So even if she had a moderate amount of fibrosis, maybe stage 2, that could potentially normalize with treatment. So treating the underlying etiology can reverse some of the scarring. But for someone who already has cirrhosis, by the time you biopsy them, you may be able to keep them there, but they may progress to transplant.
Great, thanks.
Well, I want to thank you, Dr. Gray, for helping us out discussing this case. And thank you, Drew and Mario, for being on the warm seats.